Sir, I opened the room for attendees. You can start.
Okay. Atish has joined. First speaker.
Not yet.
I don't think so. She has
Can
joined.
this.
Vishnu will wait for 5 minutes and then start.
Yeah, you can wait for a couple of minutes. Otherwise, if the second person is ready, we want to start from there.
She is there. Dr. Varsha is there.
So we can. I don't know, because if the cases have been arranged in a sequential order to first do the case and then you want to show the approach.
Yeah.
Probably because I think that's you look at the case.
We can start with CISP, sir.
No, let us see. Ashish has joined, so he can start. Varsha is there.
Yes, sir.
Atish is filing.
Atish ko we can just tell them.
Yes, sir. I've called him, sir. He is joining.
He's joining.
Yes, sir.
We can wait a couple of minutes.
Yeah.
Good morning, sir. Or shall I start with my cases, second one?
I think he's just joining, Atish. So.
ठीक है. Okay, sir. Yes, sir.
Hello, everybody. So we are starting with the same sequence, na, which is there?
Yes.
Okay.
Atish has joined, so we can start. Should I call him once? Let me call him. Yeah, so he has joined, so we can start, Vishnu. Shall we start now?
Yeah, let's start.
Yeah. So, welcome all. Good evening, and welcome to this first neuromuscular subsection meeting. And on behalf of my convener, Dr. Vishnu Venugopal, he is a professor, assistant professor at All India Institute of Medical Science, Delhi. He has also joined. On his behalf, I welcome you all. And today we are going to have a discussion on immune-mediated sensory ataxic neuropathies and sensory ganglionopathies and CISPs. I mean, we see all these cases time and again, and there's always a kind of dilemma where to put the lesion. So what we have done that we'll show some cases of each level, and this will be followed by an approach discussion. And this meeting is jointly conducted by Bombay Hospital and the Government Grand Medical College at Mumbai. So let's begin. Our first speaker is Dr. Atish Kamble. He is a senior resident at Government Grand Medical College. So Atish, you are ready?
Yes, sir.
Yeah, so you can share the screen.
Yes, sir.
Dr. Rakesh, can I interrupt? So sorry.
Yes, Megha, yes.
My residents are not able to join. Can somebody share a link here in the chat box? I'll share with them.
Okay, sir. Okay, sir. I'll drop the link.
Asmita, if you can just do that.
Yes, sir. Yes, sir. Yes.
And cases we can have, you can put the questions on the chat box, And after each session, we can take a couple of cases. So yes, Atish, you can start now.
Yes. Sir, my screen is visible, sir.
Yes. Can you make it
visible,
screen?
visible. Yes, slide mode, you can put in the slide mode. Yes, perfect.
It's okay, sir.
Yeah, perfect.
Yes, sir. Thank you, sir, for the opportunity. So today I'm presenting a case series, 3 cases. Sir, my first patient, case number 1, he's a 22-year-old male. He's student with a known type 1 diabetic mellitus on insulin therapy since past 1 year. Has attended OPD with chief complaint of weakness in both distal followed by proximal since 3 months, and complaining of imbalance while walking since 3 months. The patient was apparently all right 3 months back, and he's on the insulin therapy for diabetes. He came with acute onset of weakness in both the lower limbs, which started distally, followed by progress to proximally. And he also noticed imbalance while walking with history of wash basin ataxia. And he also has a history of paresthesia in both the feet and the hands also. The symptoms has progressed to reach the state that he become wheelchair bound in a 3-month duration period. However, he doesn't give any history of bowel and bladder involvement, any cranial nerve involvement, any root pain, fasciculation, breathlessness, fever, recent vaccination or URTI, or any other history of any toxin exposure, or any history suggestive of any autonomic dysfunction. Then on examination, patient is conscious, alert, vital space stable, pupils are equally reacting to light. There is no cranial nerve palsy. And on general examination, there is postural tremors. Then in a motor examinations, however, there is no atrophy fasciculation seen, but the power examination in the upper limb, the grip is weak, rest proximal examination power is normal, 5/5. Then in a lower limb power examination, the proximally power is 4/5, but distal power is 3/5. Then tone is hypotonia in all the 4 limbs. DTR where there is areflexia and plantars were mute bilaterally. In the sensory examination, there is graded sensory loss for the pain and temperature, which is till the ankle, but there is no definite level. GPS and the joint position and the vibration were impaired in both the great toes and the ankle. The rheumatism is positive and the tandem walk is impaired. However, the sacral sensations are normal and there are no cerebellar signs. Then we investigated the patients, and NCV showing symmetrically widespread motor plus sensory, primary demyelinating and secondary axonal neuropathy is affecting predominantly distal more than the proximal, affecting lower limbs more than the upper limbs. The CSF is showing albuminocytological dissociation, and rest of the rest of the investigations for the paraproteinemias and ESR, CRP, viral markers, heavy metal screening, vitamin B12, all were normal. Then we did a MRI root scan for this patient, which is showing the lumbosacral root plexus enhancement, which is showing the post-contrast enhancement also. The patient is treated initially with MPS with no much improvement, and then patient is given IVIG, and patient responded partially. So to summarize this case, he is a 22-year-old male with history of DM with subacute onset and progressive sensory plus motor flaccid type of quadriparesis, distal more than proximal, with predominant sensory ataxia, with areflexia, with postural tremors, with NCV showing NCV showing a demyelinating polyradicular neuropathy, with CSF is showing albuminocytological dissociation. Other causes like the paraproteins, toxic, and the B12s were ruled out, and we consider atypical CIDP. The odd feature for this is there is rapid progression with tremors, with more sensory findings, with ataxia, with minimal response to MPS and IVIG. So we thought of atypical CIDP, in this case, nodopathy or anti-MAC syndrome. Then case number 2. This case is a 50-year-old lady with no previous comorbidities, has attended OPD with chief complaining of imbalance while walking since past 2.5 months and weakness of all the 4 limbs since 2.5 months. So she initially started with paresthesia and burning sensation in the feet. 1 week later, she started complaining of imbalance, which worsened in the dark with history of wash basin ataxia, and which has progressed. Which has progressed. Then she also has noticed some acute onset of weakness in both the lower limb. We started distally and then progressed to involve proximal lower limb as well as proximal and distal upper and upper limb. The patient has reached to the stage that she required assist while walking. In the negative history, she doesn't have any bowel and bladder, cranial involvement, fasciculations, or there is no history of any autonomic dysfunction, toxic exposure, respiratory insufficiency, or any recent vaccination or fever. In the past history, she has 30 years ago has history of PTB, AKT she has taken. Not other history is not significant. On general examination, besides postural tremors, the rest of the general examination is normal. In a motor examination, we found that proximally the power is 4/5 in the upper limb, but distally the grip is weak and distal power is much affected. In the lower limb power examination, the power across the ankle is 3/5 and across the hip and knee is 4/5. Then similar presentation with hypotonia, reflexia, plantar sphere bilaterally flexure. And the sensory examination, JPS is impaired in both the great toes and thumb. In the upper limb also the JPS is impaired, vibration impaired till the mid part of the tibia and in the fingers of the hand. The pain and temperature is also impaired over the feet and hand, and the rhombox wave positive and tandem walk is impaired. Then NCS is done for this patient, and which is also showing symmetrically widespread predominantly primary demyelinating polyradicular neuropathy affecting distal and distal more than proximal, lower more than upper limb. CSF is also showing CSF albuminocytological dissociation. Rest of the investigation for paraproteins, immunofixations, viral markers, heavy metal screening, vitamin B12, all were normal. This is the MRI of the patient showing the thickened nerve roots across this, and with the post contrast enhancement is also seen in this patient. Then initially patient treated with MPS with minimal response, and this patient is under our care, and we are planning plasma therapy to this patient. Then to summarize this case, this is she is a 50-year-old lady with no previous comorbidity, with subacute onset and progressive sensory plus motor flaccid type of quadriparesis affecting distal more than proximal lower limb more than the upper limb, with predominant sensory ataxia, with areflexia, with postural tremors, with NCS showing demyelinating polyradicular neuropathy, with CSF suggestive of albuminocytological dissociation. Other causes like the paraprotein, toxic, and the B12 were ruled out, and we thought of nodopathy in this patient and planning for plasma therapy. Third case is a 25-year-old male with no previous comorbidity. He presented with predominant sensory ataxia since 4 months, with weakness in the distal lower limb, foot drop since 4 months, with postural tremors since 4 months. This all stories of 4 months, subacute in onset and progressive, and without any in the negative history, there is no bowel and bladder, no cranial or the bulbar symptoms, no motor weakness in the upper limb. On examination, in the lower limb, he has bilateral mild foot drop with rhomboc positive. We investigated, so found to have prolonged latency with reduced velocity and absent in this patient. And CSF is showing 600 milligram of proteins, albuminocytological dissociation. Rest of the investigation for immunofixation, paraproteins, viral markers, metal screening were normal. This patient is treated initially with a steroid and then IVIG. No much improvement. Then started off mycophenolate mofetil. Then doesn't show much improvement. So again, we are planning plasma therapy and followed by rituximab therapy in this patient. So, and this is the MRI typically showing the contrast enhancement of the roots in this patient. So to summarize, this case is a 25-year-old male with subacute onset and progressive predominantly sensory ataxia with mild distal motor weakness, with areflexia, with postural tremors, with NCS demyelinating polyradiculoneuropathy with CSF suggestive of albuminocytological dissociation. Other causes are ruled out, and thought of atypical CIDP, nodopathy, and planning for plasma therapy. So all these, to summarize all the three cases, these all the three cases have similar kind of presentation with subacute onset and progressive sensory, predominantly sensory ataxia with mild distal motor weakness, more than the more than the proximal weakness, with postural tremors, with NCV showing demyelinating polyradiculoneuropathy with root thickening. So differentials were kept as atypical CIDP nodopathy, and the other causes in these patients were ruled out. Thank you.
So thank you, Dr. Atish. If you see, all these three cases has a fairly similar kind of presentation with a sensory ataxic, areflexic kind of neuropathies. And they all progressed over 3-4 months time, and they were quite down. They were practically wheelchair bound. And this last case is still under my care. And this patient, I remember that he had a very rapidly progressing sensory ataxic neuropathy with a very mild distal muscle weakness. And his conductions were typical like a CIDP, except that the distal latencies were in the range of 20s. So it was very significantly prolonged distal latency, and the scan showed grossly thickened proximal rootlets, and CSF, the proteins were 600, and he did not respond at all to actually IVIG and even IV MPS. And now he is on MPS. I am planning rituximab, but this was a little bit odd, atypical CIDP presentations. Thought that we'll put these cases together, and they look like nodopathies. So I think we can go ahead with an approach to nodopathies. Dr. Vishnu, any thought? Yes, Megha.
Yeah, were you able to send antibodies for these patients?
No, we couldn't. I mean, whatever was in our hand, we could do, but there's no access to these antibodies. And as of now, we couldn't do, but they look like, yeah, absolutely. As Dr. Parthare has suggested, NF155 is what we thought of, but we had no access to that. And I think these patients would respond beautifully to Plex followed by rituximab. I think this was one back. We were not very wiser. Now we are a little bit more wiser. So we'll be doing that.
Yeah, I was also going to ask this with antibody. I think if you want to send, I mean, if patients can afford it, you can still send it to Oxford. I mean, you can send it through FedEx. Only thing that you have to reach the sample within 48 to 72 hours, which FedEx can send the samples to this one. I think that is one option that we have if you want to send for paranodopathies. Oxford, Simon Randall's lab does it. That's one. Second thing was, this to call it as an atypical CIDP. I think we have been used to the term atypical CIDP. Now the current classification term is to use typical CIDP and look like CIDP variants, and there's still EFNS criteria is still. They have kept autoimmune nodopathies and the CISPs out of the CIDP classification. They consider it as a separate entity, especially the autoimmune nodopathies, because they behave differently compared to the classical CIDP. So we can discuss later. I think once that approach is also get into the picture. Yeah.
Yes. So next, let me welcome Dr. Varsha Patil, and she is a senior consultant at Bombay Hospital and Research Center in Mumbai. And she will be talking to us about the approach to nodo and the paranodopathies. So, Dr. Varsha, yes.
Thank you, sir. Very good evening to all, and thank you very much for giving me this opportunity to talk on a very exciting and a new topic. Rather, these are the hot topics in immune neuropathies, as I would like to call it. Are my slides visible?
Yes.
Please put it on the slideshow. Yeah.
All right. So basically, the concept came in because traditionally peripheral neuropathies were classified as demyelinating or axis. So then, when we said inflammatory neuropathy, they said eponyms like Guillain-Barré, which was equivalent, considered to equivalent to an AIDP, but then there came this AMAN variant, and there was some CIDP. So they, all of us have been treating them, and we know that there are some groups which respond very poorly to the conventional therapy. Very rightly put out by the 3 cases with Atish had presented and Sir had really discussed out just a few minutes back. So then, how did this concept come in? So there were these axonal neuropathy, which had this anti-ganglioside antibodies, and the common concept is that axonal variant of GP, ANAN, will have a poor prognosis. But there were these groups which would respond and had a quick recovery. So what were these? So then they termed this as a nodoparanodopathy. So it was basically to characterize this group of neuropathies who have a common pathogenic dysfunction. And here comes the concept of the node. So it is a pathophysiological continuum from reversible conduction failures to axonal degeneration. Now put this in gray specifically because not all is black and white. There is this gray zone in between these neuropathies. So at the outset, these were some really, really good papers, which I want the audience probably to go through because they give you a very clear insight into this concept. So just going into a brief terminology of what and how these nodopathies came. So way back 1871, Louis Antoine Ranvier was the first who described this Ranvier's node, but he called it as a not a node. So a little later, Nagiot came up with these myelin loops which are attached to the paranodal junction. I'll show these in the diagrams later. And then, of course, the physiology came in. So a lot of people, Levy, Tasaki, Huxley, Stampley, all of them demonstrated the saltatory nerve conduction. So much later, then in 1960s, Webster and Spiro came with these 2 terms. So he said paranodal for the paranodal ovoid of the myelin. And Strolinsky said that there is a juxtaparanodal region for the aggregated particles which are close to your paranode. So then, way back in 2015, Ansini and Kwabara came with this new category of nodopathy, where they said it's a pathophysiological continuum, as I said, from the tangential nerve conduction blocks to an axonal degeneration. This block is usually because of certain different kind of pathophysiologic mechanisms, which is myelin detachment from the paranodes, lengthening of the nodes. I'll show a few figures later to tell you what these are about. Dysfunction and disruption of the sodium channels, or homeostasis which is altered around the nodes, and abnormal polarization of the axonal. Now, what they meant here was that this conduction block may be promptly reversible without development of a further axonal loss in the TD. So then axonal degeneration may come up depending on the severity of this, and they may follow. So then we go here to see what this are they talking about. So this is your neuron and this is the axon. This is the Schwann which is surrounding. So now our focus is just on this teeny tiny yellow line that we are seeing here, which is the nodal and the paranodal region. So this node, as you can see, it doesn't have a sheath here. So which means that it is exposed to external exogenous antibodies and the cellular fluid. And so it can be a target for many antibodies. So this is your node. Now besides your node are these 3 regions. So you have the paranode, where you have this nagiotes, those things that I was talking about, where they are attached here. Then the region just beside that, which is the juxtaparanode and the internode. Now, so there are a lot of molecules which are involved in stabilization of your membrane of the nerves and this internodal region. So when we look at, again, we look at these juxtaparanode, node and paranodal regions, we look at these molecules. So why are these important? Because in different antibodies against different components gives you a different kind of a phenotypic expression. So what is it? So here we have your juxtaparanode, node and paranode. So just remember these 2-3 names because they'll keep on cropping in the slide. So when you're talking about the nodal things, basically this is neurophysin. Neurophysin are fascins which are there for the stabilization of your nerve membrane, which is attached to your gliomedulla. And here you have your gangliosides, like the GN1, which we very commonly do for your MMS. Okay. Now, this lesion is usually populated by sodium channels, very, very specific ones for these. Then you have your paranode. So in this, again, remember these three names. The neuropacine 155, that is NF155, Caspar, and contactin. So Caspar is contactin associated protein. Now this is your Caspar 1, because we have another Caspar 2, which is in the juxtaparanode. And this juxtaparanode has a high population of your potassium channels. So then this concept of paranodopathies came in because they could try to localize different types or phenotypes of your nerve problems, your AIDPs or your CIDPs or some variants of GB, depending on the different antibodies that are found. So like I told you, remember your node. So again, these three names come in. So your gliomethylene, NF186, and your ganglioside. So these are usually your acute GB-like symptoms, the motor axonal variants. Okay. Now the paranodes are usually your CIDP-like profiles. So these are your gangliosides, especially your Miller-Fisher because of GQ1B, GQ1A, and the others. Or the hot ones these days are these your neuropacine 155, contactin 1, Caspar 1, and pan-NF. So they have antibodies against both neuropacine 155 and neuropacine 186. So all of these give you kind of a picture that is CIDP. Then there is this another term that is CCDP. So there is central plus peripheral demyelination. Okay, that is quite specific for this NF155. And the juxtaparanode, as I told you, a little distant ones, these are the ones because of affection of your Caspar, where you're contacting two antibodies, and they usually present like a acquired neuromyotonia. Now, a little busy slide, but what I want you to concentrate is see, this is the a healthy node paranodal region, and this is the diseased, which is seen in paranodopathies and nodopathies. If we appreciate, there are few things that are happening here. One, if you look at your these villi which attach to your node, they're quite compacted with these molecules, but here in a nodopathy, what we have is shortening of these. And so this distance is lengthened. Then your potassium channels are shifted a little further. So the top one shows your paranodal antibodies. Okay, so your anti-contactin 1, NF51, and Caspar 1. And the down ones are your nodal antibodies. So remember these two things, NF186 and gliomethylene. Now, I'll go on to individual things, and then we'll go into a joint approach for all of these disorders. So first is your neuropathies because of anti-ganglioside antibodies. So NF186, a few patients with AMAN had a significant correlation to these antibodies, and a few had gliomethylene-like, but these were usually with the AIDP profile. So what happened is, when they studied electrophysiologically these patients, they had prolonged distal motor latencies and a conduction block which mimicked a demyelination, but they are pure motor syndrome. So what they're trying to say is that this kind of a conduction block could be because of a reversible conduction failure at the node, which is possibly because the antibodies is going and attacking them. So then in 2012, way back in 2012, Ansini and Kuwabara came up with this term. Here, the terminologies are evolving. Nobody was proposing this kind of a nodoparanodopathy thing. But they said there's an axonal block and a conduction block without slowing off the conduction velocity or temporal dispersion to differentiate it from a classical conduction block, which will eventually give you temporal dispersion. So then I'll just like to briefly show one case. This was way back when I was doing my residency. I'd like to thank Vedant Surya sir to be kind enough to give this case. So this was a 30-year-old policeman who came with overnight history. He said, I had a little exertion, picked up my kid and was exercising. And the next day I couldn't get out of the bed. So it was quadri hyporeflexic syndrome. Okay. And of course, we did, because he was so worsened, we did the nerve conductions on the day one. Now, if you do a nerve conduction and a JB on day one, you wouldn't find anything except some little terminal latency, which may be prolonged the persistence of your F phase or prolonged F phase. But here, in this guy, what we got is day two of, probably day one, it would say of the admission, but day two of illness, he had very low amplitudes. I'm just showing representatives of the median and the ulnar Cmax. We gave this guy flex because it was a fast progressive disease. Second cycle of flex, he started walking. By fifth cycle, he was absolutely fine. So he repeated his conductions. And day 7, what we can see is the amplitude, which was so low, jumped up to normalization, both in ulnar and median nodes. So this was probably a case of reversible conduction failure. So next group is your MMNs, multifocal motor neuropathies. So quite well known, quite old entities. Slowly progressive, persistent motor conduction block. But without a temporal dispersion. In different now. So there are
some connection issue with. Asmita?
I think
Hello?
did you lose
I
her?
think
Yeah.
Varsha has accidentally logged out.
Yeah, sir. Her network is very low.
So can just ask her. Should I ask her? She can join again. You have her number, Asmita?
No, sir. I haven't.
Then let me just talk to her once.
Sir, we'll call, sir.
Just call. Yes, Varsha. Yes. Acha. No, you are logged in or Dr. Varsha got logged out. She is joining again. Meanwhile, we can have some discussion on this reversible conduction blocks, which we see in patients of Aman, and they are now, or even in multifocal motor neuropathy with conduction blocks, which are now thought to be a kind of nodopathies. And yeah, Vishnu.
Yep. I mean, practically speaking, all GBS, CADP, all semantics, all are nodopathies and paranodopathies. I think some we know about, some we don't know about. I mean, antibodies we know, something we don't know about. I think with time, in the next few years, we'll get more about nodopathies and the distinction between these conditions where autoimmune nodopathies and the classical conditions may blur a little bit once time sets in. And Kadilka sir is also there. I mean, it's
Sir is there.
Sir,
good evening. Yes, sir. Good evening.
Good evening. Good evening.
Sir. Yeah. Varsha is just joining back, sir. We had
yes.
question about this Aman and this MMN. Are these variants of nodopathies? And that's where Varsha was.
Yeah, I think. Like both of you said, it's still not clear, and as time goes by and we have the antibodies with us, and do them in some patients, we will then exactly know where we are.
She has joined, I think. No. Meanwhile, is there a, like, we always had some doubt whether we should be given rituximab in some patients of GBS which look like Aman, who have not received IG. And what do you think, whether rituximab in patients of what looks like GBS?
Dr. Varsha joined.
Joined Hathi. Let us, I think, finish off her talk.
Very sorry for very bad technical glitch.
No problem, Varsha. Yes.
I don't know where I ended up. Continue from MMN onward. So right. So then we go on to the next group, which was the ones that are related to the paranoids. So we have your CIDP, which probably is the 3 cases which Rakesh had presented. I would rather put them in one of these groups. So we have this NF155, the PAN-NF, the contactin, and the contactin Caspar complex. As you can see, I forgot to go over all of them. So I may skip this part just to emphasize that, there are these things that are there. So some may have initial diagnosis as GP. There's a prominent ataxia, tremor in some, respiratory failure, autonomic dysfunction in some, and nerve root abnormality. So then the first one is the NF155. So they're generally young onset patients, very aggressive or severe to begin with. Predominantly distally motor. There's a prominent sensory ataxia and adrenaline, and a very good response to rituximab. They have high CSF proteins, prominent radicular involvement, and a marked symmetric hypertrophy of the cervical and lumbosacral roots. And pathology is usually destabilization of the paranoids. So in contrast, we have the other group, which is the contactin, which is a little older people, but again very severe. So these are ones which rapidly progress, have very good response to steroids, but a very poor response to IVIG. So these again are through blocking of this Caspar contactin NF55 complex. And the next group is, of course, your Caspar-1. Now, these are not many. So out of 57 patients that they studied of GB and CIDP, 1 each had this Caspar-1 positive. What's prominent about them is that neuropathic pain and resolution of the pain with rituximab. Then we have this group of pan-neuropathic antibodies. So pan, because there are 2 antibodies that they are against. So these present as GBS, they are aggressive at onset. They have cranial nerve palsies. They can have respiratory failure, autonomic dysfunction, may be associated with other immune problems like your lymphomas, leukemias, necrotic syndromes. They have an incomplete response to your first-line therapy. So I'll just go over a case. This was an 8-year-old boy, which I had been managing with my colleague Venkatesh and the guidance of Dr. Thali Patel. So we had this 8-year-old boy. He presented initially like a GB. So given IVIG, improved. Again, worsened after 14 days, again given IVIG, a partial response. And further, about 2 to 3 months into the illness, went into a respiratory failure. This boy had these 3 prominent features of the severe neuropathic pain, described pain, a lot of ataxia and tremor. In the radiology, we found thickened, very thickened brachial and lumbosacral plexi, and thickened cranial nerve peripheral branches. So just to show in a cartoon what his entire progress was. So this boy from 0 MRS, there's absolutely no difficulty. Went to a foot for, took his IVIG, also given an IV methyl at that point. Dipped down, again got an IVIG, improved. By this time, started on oral steroids because it looked like something not like a routine CD. Then went on to worsen and up to the bypass. And that's the time when we flexed him. We gave him the flex. 2 days, 2 cycles of flex, he came out of it. came out of the non-invasive ventilation, and so to say, later on, we gave him rituximab oral steroids. We've been tracking this child for around 2.5 years, and now he's absolutely into complete remission. So the only thing we couldn't do was do it with antibodies. This happened in the middle of the pandemic, so we had no access to send it to even an Oxford lab. By the time he's improved, do I have a point in setting the antibodies? No, because studies say that the antibodies become negative once the patient goes into remission. So then this specific group of neuropathy 155 associated CIDPs. A lot of papers came in, and what prominently came in was that we have this trigeminal nerve hypertrophy like we had in our chat, and some of them have both CCTD, so the central demyelination that can happen. So then there's a very good paper which shows how the peripheral nervous system tracks with the disease and correlates with the antibody levels, and how the CNS involvement can also happen, but asymptomatically. So just to show two of our cases, this was of course the little boy. You can look at the markedly thickened brachial plexi, being thickened up to the intercostal nerves. The markedly thickened lumbosacral plexi, and thickening of branches of the fifth nerve. This was another 35-year-old male who came with a CIDP and had incidental central demyelination. So he had a medullary lesion which is not enhancing, and an optic nerve signal again not enhancing. What he came out was predominantly more like a sensory syndrome, ataxia. So we have this immunopathology studies from this very recent paper. If you look at the normal, so this is what is the cartoon, and this is what would be seen in the microscope. We can see, as I had explained to you earlier, there is a nodal lengthening, displacement of your potassium channels, and there is a shortening of these myelin loops. If you see it in the figure here, you can see this is the node and the parent node, how it is enlarged here. And this is to show how there is the loss of these transverse bands and lengthening. Very beautiful. So then the next group is your neuropathies due to juxtanode affection. So the antibodies can be due to the PESPAR2 or contactin 2. This is usually acquired neuromyopathy. Now, why is this look important? Because some patients with the sensory motor neuropathy had this positivity. They responded to very aggressive ones. So they responded not to the routine treatment, but to other therapies. So then the question comes is, when do you suspect a nodoparanodopathy? So they have to remember certain points which should be. So acute to subacute onset, predominantly distal motor neuropathy with a rapid progression. Severe neglect of this ability. Severe sensory ataxia and tremor, neuropathic pain, cranial neuropathy, or sometimes the autonomic dysfunction, respiratory insufficiency. They can be also associated disorders. But why are we doing all of this? Because we want to treat them. So what's important to know is that, not but now, as always, they are less responsive to IVIG, and there's a basis to that, and they are very responsive to your plasma exchange, rituximab, and corticosteroids. In the electrophysiology, of course, we know you can get a reversible conduction failure, and you can have marked prolonged latencies like the neuropathy 155 associated. And sometimes even discrete CMR amplitudes. Radiology, as we saw very prominently, you can have nerve enlargements, and histopathology is also shown earlier. So then, what is all this about no response? So basically, the immunoglobulin, the IgG1 and the IgG4. So if this is the immunoglobulin G has 4 subtypes, so IgG1 or the IgG4, how are they different? Because this is the area where the complement binds. So the IgG4 is a little bent, so there is no place for hindrance for the complement binding. And so what your routine IVIG that you give usually goes and binds to the complement. So of course, it will not bind to your antibodies. Okay. So now the IgGs, of course, antibodies do not fix the complement. This is the most important thing. Then how do you treat them? You can achieve a prolonged suppression if you don't give the IVIG, but alternative therapies like your flex or the rituximab. So this is an absolutely nice flowchart. If you look at it, you suspect a nodopathy and you have an AIDP in the body. Look at the course. If the phenotype is very aggressive at the onset with an early exon loss, go straight to the reduction. then you have these two prongs. So you are here, patient is lingering around. If you have a chance, you have a lab where you can send the paraneuropathy. If you can't, treat them like a suspected paraneuropathy. So give them corticosteroids with IVIG. Look at the response. If the corticosteroids or the IVIG is working, go slow on the escalation. If they are refractory, like our child, and the antibodies or the antibodies come positive, go straight to flex. There's no response with that, then go straight to rituximab. So it's very good result. So what are the key points to note in nodoparaneuropathy? So basically, it's a dysfunction or disruption of the axial limb at the nodal region. It's a pathophysiological caregiver. Conduction block is because of these three different types of different pathologies. It may be reversible, but we require serial electrophysiological studies to document this reversible conduction block. So why is that again important? Because your atypical presentations of GB or CIDP, you need to keep your eye open and try to send early testing or try to see alternative treatments rather than going stepwise. These are less responsive to your first-line therapies like IVIG. So not to forget that there's a very good response to steroids, flex, and rituximab. With these kind of therapies, you can go into complete remission and a meaningful recovery. So even if they may have a very severe disability at the nadir and you're able to achieve remission, it's more and more gratifying. And here the key would be to the monoclonals. Of course, we know newer therapies may emerge. Thank you very much.
Yeah, excellent, Dr. Varsha. It was an excellent review of approach to nodo and the paranodopathies. And there are many questions, as we know, we still don't have the antibodies. But yes, clinical phenotype does look quite uniform in all the patients. And I think there is a message of using early plex and I think rituximab, as mentioned. And this is a great paper written by Dr. Speaker, sir.
Know that they're doing. I've heard lab for
Yeah. So any comments, or then we can move to the next. Thank you, Dr. Varsha. Thank you so much.
I have a question. Yeah, Dr. Varsha.
Yes. Yes.
Yeah, so we come across all these patients sometimes with severe GBS. You recommend that we give rituximab to these patients if they don't respond? That's going to be the question all of us have. Even Dr. Rakesh sir was discussing that question. Anybody, any comments on that?
And Dr. Magna, I'm tempted to ask everyone to do a RCT on IVIG versus rituximab.
Yes.
I think that's a need. I have a strong gut feeling that rituximab even may be superior to IVIG. I mean, you can't be sure. I mean, you have to.
Yeah, but then the time to onset of action for rituximab is
yeah, there's a time. So what when even ethics committee will not be, ethics committee is unlikely to give you so probably what we can do is give an IVIG after 2 weeks. If then there's no, I mean, absolutely you are seeing the node there, then you randomize into give rituximab or not. If eculizumab can be given as a trial in IVIG, I think, I mean, a trial in GBS, I think still rituximab should be studied.
Yeah.
Yeah.
Okay.
Nice talk, Varsha.
Fantastic, Dr. Varsha. So I think let's move on, and now we'll go to another level of sensory ataxia, and that is the sensory ganglionopathy. And Dr. Amna, who is a senior resident at Government Grand Medical College, will show some cases which we had of sensory ganglionopathy, and then we'll have an approach discussion. Yes, Dr. Amna.
Yes. A very good evening to everyone. Firstly, I'm very thankful to Dr. Rakesh Singh sir, Dr. Kharlka sir for giving me the opportunity to speak on this platform. I hope my slides are visible. Hello?
Yeah. Yes.
Yes, sir. Yes, sir. So I'll be starting with my cases. My first patient was a 42-year-old male. He complained of vague discomfort in both thighs with the difficulty in chewing since last 1 month. While resting, he feels something is creeping along his anterior thighs and which slowly progresses over the whole lower limbs. This abnormal sensation wanes off when he used to stand or he used to walk. While chewing, he used to feel his jaw becomes abnormally tight and it causes incoordination. At this stage, his nerve conduction studies were normal. Then, in his further stay in the hospital, he developed paresthesias in the face and jaw incoordination. These paresthesias now started progressing in a downward fashion and started involving the trunk, upper limbs, abdomen, groin, and entirely to both the lower limbs. And he started complaining of numbness in his entire body, but he could feel touch everywhere, and he could and pinprick also everywhere. He could differentiate between hot and cold water when he was taking a bath. But progressively, he started slowly developing imbalance on walking, which was causing falls. And he noticed that this imbalance was worse when he was closing his eyes in the washroom, or especially when he was walking, like with the lights off in his room. So, but the facial and hand incoordination, it made him dependent on caregiver for feeding. And slowly the imbalance started worsening, and it worsened to the point that he became bedridden. And he was in a state where he could not even turn in the bed on his own. Apart from that, he did not complain of any weakness in his limbs. There was no complaint of any wasting of the muscles in his limbs. There was no complaint of any backache or radiating pain in the lower limbs. He did not complain of any band-like sensation in his chest or abdomen, any shock-like sensation on flexing his neck. He did not have any bowel bladder complaints at all. No bulbar complaints of dysphagia, dysarthria, and he did not have any visual complaints also. In personal history, he was a very healthy freak personality, and he used to be constantly eating a lot of vitamins and protein supplements, especially during this COVID times. And he was like very keen on taking a healthy diet. He was facing some sleep issues in the last few days because of work-related stress, but importantly, he was taking a lot of supplements. And in past history, he had recovered from a recent viral upper respiratory tract infection 1 week back. So to summarize, this is a 42-year-old male who has a short duration of a neurological disease, which started with discomfort and paresthesias in the thigh and jaw region, which progressed to involve the entire body with numbness in the entire body in a non-length dependent asymmetrical pattern with severe incoordination and ataxia, which is predominant sensory, and it made him bedbound. So with this short history, we felt that the possible structures that could be involved are either the root involvement or involvement of the dorsal root ganglia. The possible etiologies we kept in mind at this point was either an immune-mediated process or infection, or paraneoplastic because he progressed so rapidly. And also we thought of toxic like pyridoxine excess because he was on so many supplements, and pyridoxine excess can also sometimes cause a presentation like this. So at this point of time, the differentials that we kept in our mind was maybe a Miller-Fisher syndrome and maybe some type of a GB syndrome, or it can be a ganglionopathy. And on examining the patient, he was averagely built and nourished. His cognition and cranial nerve examination was normal. His motor system examination was absolutely normal, with tone and power was 5/5 in all the muscles. He had a generalized areflexia. In sensory system examination, he had pseudoheterosis in both the upper limbs. He had a severe proprioceptive loss with joint position and vibration sense severely impaired in the lower limbs up to the knees and in upper limbs up to the elbows. However, his pinprick, temperature, and touch sensations were normal. Cerebellar examination was normal. Romberg's and gait could not be assessed in him because he was so severely ataxic that he was not able to stand on his own. So with the examination, the key points are that he had severe proprioceptive loss, generalized areflexia, and sensory ataxia. So the summary after our examination is that a 42-year-old male with acute onset, progressive, asymmetrical, large fiber involvement in a non-length dependent manner, and jaw incoordination with sensory ataxia, generalized areflexia, severe proprioceptive loss, and pseudoathetosis without any motor, cerebellar, bulbar, and autonomic involvement. So our final localization that we considered is a dorsal root ganglia and trigeminal ganglion sensory neurons and their central and peripheral sensory projections. Also, we thought of maybe it can be root involvement also. And the differentials after our examination was mainly a sensory ganglionopathy, or it could be like a sensory CIDP or a CISP. So on investigations, his nerve conduction studies were normal in the first 2 weeks. First week interval, the first 2 studies that were done. In the third week, he showed symmetrical axonal affection of all the snap amplitudes in upper limb and lower limb with normal CMAPs, and that favored a ganglionopathy. And rest all his examinations like the ANA blot, test for Sjogren's, his MRI brain with spine, PET scan, CSF studies, and also we did a pyridoxine level for him, and everything turned out to be normal. So we diagnosed him as a case of an atypical post-viral ganglionopathy, and we treated him with a 5-day course of 2 gram per kg IVIG with physiotherapy and exercises. And he showed improvement in his negative sensory complaints and in his incoordination and ataxia also over a period of 2 to 3 weeks. At present, he is independent for all his daily activities, but he requires a walker for walking and balance. He's taking a few steps on his own. So he has having some residual disability, but he's also slowly recovering. My second case was a 48-year-old male. He presented with progressive tingling, paresthesias, and numbness, which first started in the left half of his face 8 months back. And then it started progressing to the left upper limb, then right upper limb, then bilateral lower limbs. And then over a period of 2 to 3 months, he started having numbness in his entire body. And in the same way, he could feel the temperature differences of hot and cold water and touch sensations in his entire body, but his body was numb, is what he said. He gradually developed an imbalance on walking with tendency to fall, and this was again worsened in the dark when he used to close his eyes. The imbalance started progressing, and in a period of 2 months, he was at a state that he could not even stand without support and could not take a single step without support. He did not have any other weakness in the limbs, no wasting, no backache, radiating pain, no band-like sensation, no sphincter disturbances, no bulbar and visual complaints. He was a known hypertensive, otherwise no other significant history. So to summarize, he's a 48-year-old male with a chronic 8-month history of facial numbness and paresthesias, which progressed asymmetrically in a non-length dependent pattern to involve all 4 limbs, followed by development of predominant sensory ataxia. So at this level, the possible structures involved are either the roots or the dorsal root ganglia. The possible etiologies that we considered are either an immune-mediated process, or it could be paraneoplastic condition, or also it could be idiopathic. The possible differentials that we considered were sensory ganglionopathy or a sensory CIDP. On examination, his cognition and cranial nerves was normal. His motor examination was absolutely normal. He has generalized areflexia. And on sensory examination, he had pseudoathetosis and severe proprioceptive loss with loss of vibration in the upper limbs up to the elbows, in lower limbs up to the knees. His Romberg's was positive, but his pain, touch, and temperature sensations were largely preserved. His cerebellar examination was normal. He was not able to walk on his own, but he was managing to take few steps with a walker, and we noticed that he was having a high steppage gait. So it was after examination, our final summary is that he's a 48-year-old male with chronic, progressive, asymmetrical, large fiber involvement in a non-length dependent pattern with sensory ataxia, pseudoathetosis, severe proprioceptive loss, and generalized areflexia without any motor, bulbar, cerebellar, or autonomic involvement. With this, our final localization was at the dorsal root ganglia and the trigeminal ganglion sensory neurons and their sensory projections. Also, we kept query a root involvement can also present like this maybe, and our differentials were again the same after examination with sensory ganglionopathy or a sensory form of a maybe CIDP or a CISP. On investigations, and his nerve conduction studies were done 3 months after his onset of symptoms. So he showed absent sensory potentials in all the nerves of the upper limb and lower limb with preserved CMAPs in all the nerves that were tested. So that clearly favored a ganglionopathy. And he was thoroughly investigated where nothing was found to be positive. His ANA profile, protein electrophoresis, triple H, paraneoplastic antibody panel was also done for him. MRI, lumbosacral plexus, PET scan, CSF studies, everything did not show any remarkable results. So we finally labeled him as an idiopathic sensory ganglionopathy, and we calculated a sensory neuronopathy score for him, where for a probable sensory neuronopathy, the score should be more than 6.5. And based on the 5 parameters of ataxia, asymmetrical sensory loss, and sensory loss not restricted just to the lower limbs, and absence of snaps, and with normal CMAPs, he got a sensory neuronopathy score of 12.7, which indicates probable sensory neuronopathy. Actually, when this patient came to us, he was already treated outside with IVIG, full dose. When he came to us, he was already 2 months post IVIG, and he did not have any improvement. He could not, his condition was not worsening, but he was the same like he was since 8 months. So we observed him for a period of few days, and we decided to treat him with secondary immunosuppression with rituximab, that we gave him 2 doses, that is 2 grams, 2 weeks apart. And gradually, when he has come for follow-up with us, he is showing some improvement. He is able to take a few steps without support. So we have advised him for, there is quite a lot of improvement in him as compared to before. He could not think of standing without a walker. Now he is standing without a walker and taking few steps. So we are advising him to continue the rituximab injections every 6 monthly with physiotherapy and balance exercises. Thank you.
Yeah. Thank you, Dr. Amna. Excellent. Excellent case. So these cases were typically of sensory ganglionopathies, and as you saw, one of our patients was a health freak. He was taking a lot of health supplements, and he came in a very rapidly progressive manner of initially Miller-Fisher syndrome like picture, but then he had gross sensory impairment everywhere in a typical non-length dependent pattern. And we thought maybe he has taken excess of pyridoxine. We did the level also, which came negative. After IVIG and some more further IVIG courses, he at least now able to walk. He was not able to even stand in the beginning. Now he's walking without support. He still has a lot of problem, but at least able to walk now. So let's see the approach of ganglionopathy. And ganglionopathy we all diagnose, and often we don't know the cause of it. And so we have Dr. Megha Dhamne. She is a neuromuscular expert at PD Hinduja Hospital here in Bombay. And she will take us through the approach to sensory ganglionopathies. Yes, Dr. Megha.
Yeah, thank you, Dr. Rakesh, and thank you all for inviting me for this talk. So Dr. Amna has given a very lucid presentation of 2 cases. One was acute presentation and the other one was a chronic presentation. So let us jump to how do we look at these cases when they come to us with a sensory ganglionopathy kind of a presentation. So the question is, why sensory ganglia? So sensory ganglia, as we all know, are cell bodies of sensory nerves, and they are susceptible to the autoimmune attack because of lack of blood-nerve barrier. There is a primary degeneration of sensory neurons in the dorsal root ganglia, which is seen in autopsy studies, in biopsy studies. And pathologically, there is a T cell reaction, which is seen, which suggested an immune-mediated response. So jumping straight away to the clinical features, how are these different from common peripheral neuropathies that we see? So as the term indicates, sensory neuronopathy or a ganglionopathy, there is no motor weakness. Sensory symptoms start from any part of the body. So this is classically described as a non-length dependent, as we have seen in these 2 patients. Sensory symptoms may start from the face, from the upper extremity, one side, the other side, chest, and then spread to all the other parts of the body. They may sometimes be limited only to certain parts of the body in an asymmetrical manner. Commonly, neurons of large nerve fibers are involved, leading to proprioceptive loss, loss of touch, vibration. Classically, pseudo-athetoid movements because of impairment of sensory sensations that are perceived, loss of deep tendon reflexes, and Romberg's is positive. Less commonly, however, neurons of small fiber nerves may also be involved, causing burning, tingling, stabbing pains, loss of pinprick and temperature with preservation of large fiber sensations and reflexes. Autonomic nervous system symptoms may also be seen. Now, as proximal projections of sensory ganglion cells form the posterior spinal roots, and they contain the spinocerebellar fibers, it may sometimes resemble cerebellar ataxia. So in some of these cases, we see there is a component of cerebellar ataxia as well, but without dysarthria and nystagmus. These neuronopathies may progress more rapidly over days to weeks than typical polyneuropathy, and it is more severe and disabling. So a presentation of a patient with a proximal sensory loss, or I would say asymmetrical non-dependent sensory loss with prominent sensory ataxia, preserved strength, may or may not be with autonomic symptoms involved, you think of a sensory neuronopathy. What investigations would you do? CSF shows elevated proteins and mild pleocytosis or oligoclonal bands. Nerve conduction study plays an important role. As we have seen in the first patient, it may be normal in the early phase. Sensory responses may be absent or reduced with relative sparing of sensory latency and conduction velocity. So no features of demyelination are seen. Pattern is again asymmetric, non-length dependent. If the face is involved, you may have an abnormal blink reflex suggesting involvement of trigeminal ganglia. Most important to note, normal motor conduction studies, mild reduction in CMAPs may be seen, no demyelinating features, no axonal features. You will have a normal needle electromyography. Other investigations that may be done are autonomic testing, skin biopsy for a small fiber ganglionopathy, again showing a non-length dependent loss of intraepidermal nerve fiber density. So what that means is you do skin biopsy in the thigh and the distal leg. The area in the skin biopsy from the region of the thigh will show loss of intraepidermal nerve fiber density as well as normal density in the distal nerve segments. Now, MRI shows increased T2 and signal and enhancement in the dorsal root ganglia and the posterior column of spinal cord. If a biopsy is done, it shows CD8 infiltration in autoimmune cases. And the other investigations, we'll talk about this, to rule out the underlying cause and differentials. So, is there a diagnostic criteria for sensory ganglionopathy? Basically, a non-length dependent distribution of sensory loss and nerve conduction studies showing clearly a sensory involvement alone or a predominant sensory involvement is a sensory ganglionopathy. This was proposed by Asbury in 1987. But the problem with this is it's a very simple diagnostic criteria, and it did not include mild motor abnormalities on electrodiagnostic studies, which may be seen in sensory neuronopathy. So hence, Camden Sankey, I don't know how to say this. So he did a very nice case control study. It was a nice paper published in Brain 2009. So he put up a scoring system and put up a diagnostic criteria for sensory ganglionopathy. Basically, what he has suggested is ataxia. So sensory ataxia, asymmetrical distribution, non-length dependent pattern. That's a clinical criteria. As far as electrophysiology, you need at least one sensory nerve potential, which is absent, or 3 snaps, the amplitude less than 30% of the lower limit of normal in the upper limbs. And as far as motor abnormalities, we need less than 2 nerves with abnormal motor nerve conduction studies. And supportive criteria, presence of onconeural antibodies, cancer, cisplatin, Sjogren's syndrome, MRI abnormalities. A definite diagnosis is, of course, a dorsal root ganglia biopsy, but this is not recommended. So looking at a patient who presents to you with a sensory ataxic neuropathy. Let's look at the scenario here. Abnormal sensory nerve conduction studies and normal motor study. This is our patient with a classical sensory ganglionopathy or a neuronopathy. The only differential here would be a pure sensory GBS. I will touch base upon this in the subsequent slides. Now, if you have normal sensory studies and normal motor studies and a patient with a severe sensory ataxia, the lesion is probably proximal to the dorsal root ganglia. So these are your chronic immune sensory polyneuropathies. There is another talk on that. I will not touch base on these. So the other group of disorders where the sensory nerve conductions are abnormal and motor nerve studies are also abnormal, and there are features of demyelination, like the first patient in our case, but however, he did not have features of demyelination. So Miller-Fisher syndrome is an acute presentation. If it's chronic, CIDP, the nodopathies, and CanoMad are the differentials. So I think electrodiagnostic studies, accurate electrodiagnostic studies will help you distinguish these patients with sensory ataxias. Now, is there a hereditary variant of sensory ataxic neuropathy? Yes, you can see it in mitochondrial diseases, spinocerebellar ataxias with neuropathy, Friedreich's ataxia, inherited disease of fat malabsorption with vitamin E deficiency. So what else do we need to rule out? Apart from dorsal root ganglia, root, and neuropathy are spinal cord pathologies because of the severe proprioceptive loss. So dorsal column may be involved, and hence MRI needs to be done on these patients to rule out treatable causes. Okay, I'm going to stop here and go back to our patient because there are a few things which would be useful to discuss. The first patient which Dr. Amna presented, the 42-year-old gentleman who presented with a rapid course of sensory ataxia, bedbound, and who was taking a lot of vitamins, received IVIG, and with a slow improvement. So the question is, there was a differential diagnosis which has been discussed, but one question which we can ask is, he did not have any demyelinating features on his nerve conduction studies. So with a sensory ataxia, could this be a pure sensory GBS as a differential for a sensory ganglionopathy? Okay. Anybody who wants to type in the chat box, we can have an audience poll. I mean, we've discussed about sensory ganglionopathy, but could this still be a pure sensory GBS? And he responded to IVIG is one thought which I was thinking about when I was going through the literature. So there are few papers which talk about pure sensory GBS. Does it really exist? And how to distinguish it from a sensory neuronopathy? So this is an extremely rare entity. Typically in a GBS, you would see some motor involvement, either clinically or electrophysiologically. For these cases, CSF will show elevated proteins, so which will not help in distinguishing. Nerve conduction studies will be helpful because demyelination is seen in sensory GBS as well. But however, if you have a pure sensory GBS, demonstrating demyelination itself is a difficult task, because absent snaps will not help you differentiate between whether it's a demyelinating or an axonal GBS or a sensory neuronopathy. However, absent snaps with normal motor studies are in favor of a sensory ganglionopathy. Remember, GBS is a monophasic illness. Now, this patient had improved, but he had not improved completely. So his response to IV immunoglobulins was partial. That means he needs a repeated immune therapy in the form of either maintenance IVIG or any other form of chronic therapy. And a sensory GBS would have a good prognosis. So there were some papers which discussed about pure sensory GBS. Good work has been done by O, and this is a 2001 paper. You can go through that. And there also some people have tried to do sural nerve biopsy to show pure sensory GBS they've shown demyelination in these patients as compared to normal controls. So it's a rare entity, but something to think about. Okay, going back to sensory ganglionopathy, we all know the classic causes of sensory ganglionopathies: paraneoplastic, autoimmune, infections, drug-induced or toxins-induced, and idiopathic. As far as the cancers, the small cell lung cancer is the commonest cause of sensory ganglionopathy. Sjogren's syndrome is the commonest rheumatological disease associated with sensory neuronopathy. So investigations for etiological workup is an autoimmune workup, paraneoplastic workup. Patients need a whole body PET scan for a malignancy screen, B6 levels, celiac screen in idiopathic cases. Let's talk about a few of these sensory ganglionopathies. Amongst the paraneoplastic ganglionopathies, sensory symptoms, the commonest one we said is the small cell lung cancer. Sensory symptoms may precede the diagnosis of cancer by weeks or months, sometimes up to 5 years. So these patients need a regular screening for malignancy for at least 3 years on an annual basis. The common antibodies found are anti-HU and CRMP5 antibodies. These are the autopsy studies which have shown inflammation or loss of ganglion cells in the dorsal root ganglia and Wallerian degeneration in the posterior columns of the spinal cord. 5 to 15% patients with Sjogren's syndrome have polyneuropathy. Predominantly, these are large fiber sensory ganglionopathy. However, small fiber sensory ganglionopathy can be seen. Just last month, I had a patient who was in her 50s, presented to me with a 1-year history of severe burning in both her upper extremities, abnormal sensory symptoms, and she actually had burns on both the hands which were healing, and sensory nerve studies showed absent sensory responses. So I think predominantly she had a combination of small plus large fiber sensory ganglionopathy, and her autoimmune workup was positive for Sjogren's syndrome. We started her on steroids. So these patients, they may not have Sika syndrome at the onset, as in this patient which had come to me. So less than 50% of them may be symptomatic for Sjogren's. Antibodies may be positive in about 50% of the cases. However, if a strong index of suspicion, we can do these ancillary tests, Schirmer's and salivary gland biopsy. Other rheumatological diseases are less commonly seen. This is how a Schirmer's test looks like. All right. There was a 32-year-old male who was referred to us with an acute sensory ataxia, and he was being treated with MDR, with TB medications. He was a case of MDR tuberculosis. Treatment was almost completed. He had taken a year of treatment. And the question was, whether this was, the clinical presentation gets complicated in MDR TB, specifically because they are on polytherapy, including these drugs like linezolid, cycloserine, moxifloxacin, which are all neurotoxic. We know pyridoxine causes sensory ganglionopathy. However, other drugs also play a role here, and the diagnosis can be challenging in these patients. This patient had, in fact, impaired proprioception, sensory ataxic gait, but he was hyperreflexic, and I could not explain why his reflexes were not absent. So we did his imaging, and the spinal cord imaging was normal. CSF was marginally increased proteins. And the question is, what do you do? Do you offer IVIG? Pyridoxine levels were normal. So would you just do physiotherapy? Other medications, linezolid, cycloserine, moxifloxacin, all were stopped because of the development of a neuropathy. In fact, the patient was poor and he did not do anything. He refused IVIG. Eventually, what happened is after 3 months, he improved gradually. He's walking now normally and he's happy. So I feel this is a drug-induced sensory neuropathy, may not be a neuronopathy. because of hyperreflexia, and the pyridoxine levels were normal, and he was on this polytherapy. So probably it was neuropathy which confused the picture. Coming back to pyridoxine toxicity, is more of a good thing better? So this is what the question is. And 1983, there was a nice paper in NEJM, first studied on 7 adults with ataxia who presented with ataxia after day high level of pyridoxine consumption. And these patients may not reverse completely even after stopping the medication. So most of these cases of pyridoxine toxicity have resulted from very high doses of pyridoxine. This paper talks about the effect of pyridoxine on the development of neuropathy, and you can see, so this is 150 milligrams per day, and this is 200 milligrams per day. The development of neuropathy appears to be dose dependent. However, even lower doses, the duration of treatment may be an important risk factor in these patients who develop sensory neuronopathy. Now, coming to chemotherapy-related ganglionopathies, the common medications are cisplatin, carboplatin, and oxaliplatin. Symptoms typically occur 3 to 6 months after starting the offending medication. But we may see 3 to 6 weeks after discontinuation, the onset of these symptoms and progressive worsening, and that is a coasting effect. So the mechanism of neurotoxicity is probably apoptosis of the sensory ganglia by the platinum compounds, and the binding of the binding to the mitochondrial DNA may explain the delayed effect, which is the coasting effect after drug discontinuation. Now, it's important to note that these patients may also have a possibility of a paraneoplastic ganglionopathy, right? Because these are patients who have had an underlying cancer, and we need to differentiate because paraneoplastic syndrome is treatable neuronopathy. So these patients will have positive antibodies and they will show high CSF proteins. Another important point in chemotherapy-related ganglionopathy is that the symptoms may progress for weeks despite drug discontinuation and may slowly improve, or they may incompletely improve. Coming to the treatment of sensory ganglionopathy, use of immunosuppressive therapies such as steroids, steroid-sparing agents, immunoglobulins, rituximab. Treatment of underlying cancer may fail to show improvement in some, and this is probably because of destruction of cell bodies of the sensory ganglia. However, important to note that immunotherapy may halt disease progression, and that should be offered to all our patients with sensory neuronopathy. And it has shown that early treatment within 2 months of the onset has shown to improve symptoms, and it has shown to stabilize the disease by about 8 months or so. With that, if we have time, can I discuss this difficult case that we have?
Yes.
Only if we have time.
Yeah. You can discuss in short. Maybe.
Yeah, so this was a patient, 49 years old lady. So she had an insidious onset of symptoms. See, so basically non-length dependent, started in the feet and the hands first, and then involving the slipping of chappals, grip difficulty, imbalance. So you can see from 2015 to 2019-22 now, over the last 6 to 7 years, she's had these chronic progressive symptoms. However, which was odd was she had a slurring of speech as well in the last 1 year. So clinically, classical severe proprioceptive loss, sensory ataxic neuropathy, which looked like a sensory ganglionopathy. However, she also has this slurring of speech, and a left eye ptosis was something which was odd in the presentation. So she probably had, the question is whether there is a cerebellar component with underlying sensory ataxic neuropathy, and now there is ptosis as well. So is it a sensory ganglionopathy or an additional cerebellar component? So thinking of CanoMad as a differential in this. These were just my thoughts when I first saw the patient. Now, she gave a history of third degree consanguineous marriage in her parents. No other family member was affected. So we wondered if a hereditary neuropathy, sensory ataxic neuropathy, such as a Sandoz syndrome with ophthalmoplegia and dysarthria should be considered. So with these thoughts, we did an extensive workup on her, which was essentially negative for a possible mitochondrial disease. Serum and CSF lactate levels were done, which was normal. CSF studies showed a mild elevation of proteins. Coming to nerve conduction, there was some features of demyelination as well, but very subtle, as you can see here, with a conduction block in 1 to 2 nerves in the upper extremity. It's a really complex case, and I really don't know what is the diagnosis here. So I will appreciate if any thoughts from the audience here. A patient who's presenting with subacute onset, chronic onset, chronic progressive sensory neuronopathy with a cerebellar component, possibly and ptosis. That's where we are. And I have sent her hereditary, the genetic test as well. Given her IVIG, she has just received IVIG last week, so I don't know how, but we did not see a dramatic improvement in the clinical symptoms. I think I just leave it over there. Thank you so much and appreciate any comments on this case.
Excellent, Dr. Megha. Fantastic approach. And since we are running short of time, I think 1 or 2 questions we can take. You raised a very important issue of sensory GBS. So I think we can request Dr. Vishnu. He had some thoughts on that.
Thanks. For me, I think the major, first main clinical pointer towards differentiating between a sensory GBS and a ganglionopathy is the severity. So ganglionopathy is always very severe. It is I call it as most of the people call it as a counterpart of motor neuron disease. It's like you knock off the whole ganglions of the body. It will be very, the severity is the most crucial point. And sensory GBS, as madam has told, most of the sensory GBS have subclinical electrophysiologically motor involvement, and most of them don't stay as a sensory GBS. They 70% evolve into motor involving motor also later on. So in that case, that's the important thing. And most of the ganglionopathies at the later ages, if you can get paraneoplastic or any other autoantibodies, and as I said, Jogren is, especially if you have a trigeminal sensory neuropathy involvement, Jogren is a very interesting cause to be looked for. So in that case, I think we have running short of time. I think we're already 20-25 minutes late. I think we should go to the next case. Yeah.
So thank you, Dr. Vishnu. And let us move to the next level of sensory ataxic syndrome. And we'll be taking up cases of CISP. So Dr. Darshan, who is a student of Dr. Khadilkar from Bombay Hospital, will show some cases of CISPs, and then we'll have an approach discussion.
Yes, good evening, sir. Thanks for giving me this opportunity. Today I'll discuss regarding one interesting case of the man with dancing hands. Here was a 27-year-old male presented with tingling numbness in both hands since 3 years and numbness in both lower limbs since 2 years. Premorbidly, he was a cyclist, a marathon runner, a piano player, and he had a desk job almost daily for 13 to 14 hours. He was relatively all right till mid-2020. Then he noticed tingling numbness in both hands since June 2020. Initially, it was mild. It gradually progressed to him having more and more numbness in hands, with difficulty in breaking chapatis, difficulty in buttoning and unbuttoning, not able to hold the pen properly, and ultimately could not write at all. Things would drop from his hands and he would not be able to do the fine activities he would be having difficulty in playing the piano. He could not feel touch in the hands and could not make out things in his pocket unless he looks at them. There was history of tremulousness in both upper limbs simultaneously during this period. Since early 2021, almost after 1 year of illness, he started feeling numbness in his toes bilaterally with difficulty in using the accelerator and brake. He also started having difficulty in handling the slippers with history of slippage of chappals. The numbness increased to both thighs also gradually. There was no any difficulty in getting up from squatting position, no any back pain or bend-like sensation or shock-like sensation or neck flexion, no bowel or bladder symptoms. There were no any autonomic symptoms, no weight loss, no drug history, and no any other prominent symptoms. He was not a diabetic or hypertensive, nil addiction history he had, and his appetite was normal, his sleep was unaltered. There was no any family history. So to summarize, my patient was a 27-year-old male with a 3 years history of insidious onset, gradually progressive neurological disease with predominant sensory complaints, started in the upper limbs distally, then progressing to involve the lower limbs symmetrically in a non-length dependent manner over the course of 3 years. So possibilities kept was either involvement of the nerve as a sensory predominant neuropathy or root, like a CIDP spectrum disorder or dorsal root ganglion. That is sensory ganglionopathy. Etiologies like infectious, Hansen's or HIV, immune etiologies, CISP, toxic or metabolic etiologies all kept in mind. So on examination, there were no any structural skeletal deformities, no postural drop of blood pressure. He had bilaterally thickened ulnar nerves, but no nodularity. There was no any cranial nerve abnormalities. I'll show the video of the patient. On asking to extend the hands, there were pseudoathetoid movements on both the sides. And here in this video, I'm asking him to hold the cup, and he's having difficulty in holding the cup, putting it in the table, difficulty in holding the glass. And also in buttoning, unbuttoning, he's having difficulties, as you can see here. We have taken the permission for the patient to show the videos. Power was normal in almost all the joints at all movements, except hand grip was mildly weak. There was no any wasting or fasciculation. All DTRs were attenuated. Plantars were both mute. On sensory examination, he had temperature, pain, sensation reduced till mid forearm in both upper limbs and up to mid calf in both lower limbs. And joint position and vibration was impaired distally only at the distal interphalangeal joints. And there were pseudoathetoid movements, as you had seen. There were no any cerebellar signs. Romberg's was positive. He could not walk tandem, and he had a high steppage gait. So to summarize, he was a 27-year-old male with chronic insidious onset, gradually progressive, symmetrical, sensory, much more than motor involvement, both large and small fibers in a non-length dependent pattern with generalized hyporeflexia with pseudoathetosis without any bowel, bladder or bulbar dysfunction. Investigations wise, his routine blood investigation, vasculitic profile, viral marker, protein electrophoresis, immunofixation assay didn't show any evidence of AM bands. CSF didn't show any cellularity. There was mild aluminocytological dissociation, no any oligoclonal bands or no malignant cells. In sensory and motor nerve conduction study, as you can see, there were mildly involvement of few nerves, right and left ulnar, low amplitudes were seen in the sensory and in the motor also. And here, as you can see, the F wave was mildly prolonged and H reflex was of low amplitude. All the lower limb studies are normal except absence of H reflex. But the SSCP showed sensory conduction blocks at proximal levels. Only popliteal and elbow potential were obtained. Here is the MR neurography image of the patient showing thickened postganglionic roots of the brachial plexus. So finally, it was kept as a CISP plus spectrum disorder. We treated him with a 5-day course of IV steroids and followed by oral steroids in a tapering dose and mycophenolate mofetil, along with physiotherapy. Currently, he is almost 70% subjectively better. He can write better. He can play piano with some difficulty. Currently, his pseudoathetoid movements are still present, but reduced as compared to previous state. And this was his gait recently. So quite okay. He was able to do the marathon also after the treatment. So he's a piano player. If we have time, I'll just for a few seconds will show his post-illness ability to play the keyboard.
Yeah, sure.
So even after the illness, he's doing remarkably well. Thanks for listening to my case. Thank you.
Fantastic case, Dr. Roshan. And any comments? Anybody wants to make a comment on this case? Any thoughts? Yeah.
So, sorry, sir, one comment. Sir.
Yeah, please.
So in the nerve conductions, can we go back to the nerve conductions of this patient? Did they have some motor involvement as well, or I think I missed that part? No, right?
Yes, ma'am. There was mild motor involvement, so we had kept as a CISP plus disorder, ma'am.
Okay.
Yes.
Thank you.
Thank you, ma'am.
Okay. So the level of lesion was mainly in the sensory roots, because the conduction showed only mild abnormalities. So let us now listen to Dr. Akash Chheda. He is a senior consultant at Government Grand Medical College Neurology Department, and he will show us the approach of how to approach these patients of CISPs, and then we'll have final comments by Dr. Khadilkar sir. Dr.
Rakesh, can I
Yes,
just lighten the mood a little bit?
Please, sir.
You know, this boy came for a follow-up. The boy who was just shown by Darshan. He came for a follow-up, and as soon as he came, he put out his hands. I said, "See, sir, see." So I thought he's showing me that the pseudoathetoid movements have become better. But he was actually showing his engagement ring. He said, "Can't you see I have a ring now?" He is much improved, and he ran a marathon. His would-be wife also came and met. Yeah, sorry, Akash, sorry. Go ahead.
Thank you, sir. Thank you, Dr. Rakesh Singh, sir. Thank you, Dr. Khadilkar, for giving this opportunity. So I will like to keep it informal, and I will want your comments also while discussing this approach on chronic immune sensory polyradiculopathy. When I was given this topic, a few random thoughts came to my mind. How do these patients come to me? So in a busy OPD, it is a middle-aged man who comes to you with some gait difficulty, some numbness here and there. Over a period, it is a history of some months to years. Whenever we get such a patient, we tend to figure out in our mind what is the reason for this gait ataxia. We check the reflexes. He is areflexic. And I immediately ask, okay, this is sensory ataxia, and I will want to do a nerve conduction for you. Possibility of some CIDP kind of thing. So we ask for the NCS, the nerve conduction. He comes for the next visit, which comes out to be normal. Then you again ask the patient his history, you again examine him. This time you consider whether it is vestibular ataxia, but there was numbness. You think about cerebellum, whether being missed. So you ask for MRI spine, MRI brain. This is what a busy practitioner does whenever he gets a patient. When there are many patients to see, even if a patient has got areflexia, when there are some hard signs which say that there is sensory involvement, but when the NCS is normal, we are stuck. So the MRIs will be done. The MRI would have been normal. Then the thought comes whether this is abasia, astasia. But because it is proximal involvement in CISP, the brunt of ataxia is huge. So they are really ataxic when they come to you. And it is a chronic story which makes you feel that this guy has been troubled for quite some time now. There has to be something. So there, the role of advanced electrophysiology with SSEP comes into picture. So by definition, the nerve conduction is normal in CISP, and the SSEPs will pick up the diagnosis. So that is how this CISP patient comes to a tertiary center or to a medical attention, and they get treated after the proper diagnosis. So while reviewing, so this was a paper in CISP was considered as a typical CIDP or a variant of CIDP. So these are various presentations of CIDP. The red one is pure motor, green is pure sensory symptom, brown is green plus red mixture, so sensory motor syndromes. CIDP will be proximodistal sensory motor involvement of all four limbs over a period of more than 2 months, with the electrophysiology showing classic demyelinating picture. DATS is the distal variant, which will have predominant sensory involvement. And this Lewis-Sumner is MATSAM. It will have multifocal, asymmetric, demyelinating sensory motor, polyradicular neuropathy, which starts with upper limb involvement. Then pure motor CIDP, which will have normal sensory examination and the electrophysiology. And then this pure sensory CIDP versus CISP. So by definition, CISP will have normal electrophysiology, whereas sensory CIDP will have electrophysiology abnormalities in the peripheral conduction itself. Whereas CISP, only SSEP will be affected. And Kanamod will have ophthalmoplegia and bulbar involvement. So it is secondary to paraproteinemia. We will focus today on CISP. So this is the entire spectrum. And usually it is a person who comes, when you see this diagram of spinal cord with the ventral and dorsal root, you will find the disease process will usually involve the whole of it. And usually that is what happens in CIDP. But then we started to classify them, and we tried to find out why some patients have some characteristic things, and we still delineate them. And now we have come with this only dorsal root affection, which can be seen in CISP. But I think it could be a spectrum, and soon after CISP was shown, now there are studies with CISP plus. So we see patient at a particular point of time. We don't see them throughout their illness, but they may be form first of the same spectrum, or there could be some antibodies which have some predilection for some neuroaxis part. So probably, I don't know whether CISP and CISP plus are two different things, or they are same thing pathologically, but anatomically, dorsal root affection was the one which we have called as CISP. So inflammatory radiculopathy, which affects the dorsal root and causes sensory ataxia because it is proximal root affection. It is seen in 0.5% of all CIDPs. And the adjoining figure on the right is CISP plus, wherein the dots show other part involvement also. So you will get some distal weakness. You will have some electrophysiological abnormalities on NCS, which is the more common one which we see in practice. So this was from this paper, the clinical profile, which is a very recent paper wherein they have come with this concept of CISP plus. And they say that in and around 60 years, there was median age with slight male predilection in their subgroup, and time to symptom to diagnosis was 2 to 4 years. So they usually have this chronic insidious story. And by the time they come to us, they become really ataxic, requiring support with history of falls. They usually start with distal segment, as Darshan has shown in his case. They usually have pain, paresthesia, imbalance, and then it usually goes proximally to involve the girdles. And troublesome neuropathic pain, as seen in axonal vasculitic neuropathies or other toxic causes, was very uncommon in CISP. Usually the brunt of the disease is on large fiber involvement, which causes sensory deficits, areflexia with preserved muscle strength and presence with gait ataxia. So whenever a patient with this syndrome comes to us, clinically we think about whether it is some CIDP form first, whether it is sensory CIDP, whether it is a neuronopathy, which madam had just shown, that is ganglionopathy, which gait ataxia is the main feature as all the ganglia get destroyed. Sometimes they could have chronic presentation, and some axonal neuropathies you should always keep in mind whenever we are going to think about CISP, because vasculitic neuropathies, heavy metal intoxication can sometimes progress rapidly to involve proximal segment and can have sensory predilection. Patients with diabetes can also cause a confusion whenever we are suspecting CIDP. So electrophysiology, when we see for patients of CISP, it is the SSEP which has got affected. The NCS EMG will be normal. They can have mild distal involvement in CISP plus. However, for SSEP, we will have absent or delayed proximal lumbar or cervical responses. So it is classically the segment between N9 to N13 which gets affected. So there is prolongation of N13, and the latency difference between N9 and N13 will get prolonged. So that is the segment which is affected in CISP predominantly. The same studies which we do for CIDP, we will want to do a CSF which will show albuminocytological dissociation. We will do an MR scan to look at the proximal roots, which will show thickening and enhancement. Very less frequently we do a sensory root biopsy, but it was studied in this study, and they showed onion bulb formation, which is suggestive of demyelination and remyelination going on due to the chronic immune process. And they show reduced density of large myelinated nerve fibers. Autonomic testing was done and it was normal, as it is supplied by small fiber. So coming to the treatment part for CISP, it is aggressive and early immunotherapy which is recommended, because Wallerian degeneration can set in the spinal sensory nerve roots, and they have very poor regeneration capability, as there are factors, inhibiting factors such as NOGO-A. So this part of the neuroaxis has got poor regeneration capacity as compared to the distal segment. So that is the reason we should suspect, diagnose early CISP and treat it aggressively with early immune therapy. Whenever we try to taper the first line drugs, they show relapses. So second line immune therapy with mycophenolate was suggested in this study. Thank you. These are my references. So I've kept it short and I will like others to contribute.
Excellent, Dr. Akash. It was a very nice approach which you showed how to approach the CISP, which is often very, very difficult to diagnose. And now I can welcome Dr. Khadilkar sir to have his final comments on all sensory ataxic syndromes, and especially the CISP, which sir has written extensively on that. And sir needs no formal introduction, but I can tell you he's a dean and professor at Bombay Hospital Research Center, and he is the ex-head of department at Government Grand Medical College. So welcome, sir, for your comments.
Thanks, Rakesh. Firstly, I must compliment you and Dr. Vishnu for arranging this beautiful program. I think you're keeping the neuromuscular subsection alive and kicking. So thank you very much. And for all of you who are listening, there are 6 programs through the year. 6 programs through the year. Yeah, which is, I think, fabulous. And today's topic selection was very good. you indeed covered three very important areas of the nervous system, the neuropathies, though they are all unusual. I think as neurologists, we probably need to know them. As you saw for the students, as you saw, to make a diagnosis, you need clinical acumen and you also need good laboratory support. Unless you have a good electrophysiology laboratory, unless you have a good laboratory to tell you about antibodies, it's not easy for the clinician to come around. So it's a team effort. And unless in your setup you have the whole team effort, it's not easy to make a diagnosis. So I think that's a lesson, that if you need to diagnose unusual conditions, you need a total solid combination of various things. And that's possible in large institutes in the country, outside the country. So they easily make the diagnosis. The second point that I would like to mention for everybody's thinking, that we dealt with various immunological neuropathies today. And if you see in the spectrum, you got some that are so much more sensory. There are some that are so much more motor. There are some that are exclusively sensory, some that are exclusively motor. Some are very, very distal, like the DADs. Some are distal and proximal. There are some others that are very, very proximal, like the CISP and CIMP. So obviously, within the immune spectrum of neuropathies, there is more happening at the molecular level or at the antigenicity level. The antigens probably are different. That's why the immune attack goes to different areas. So again, there is so much shortage of actual information on why this happens. And there is a tremendous scope for work as to why these various patterns are seen within the immunological neuropathies that we saw today, which actually is a very big challenge. And unless, again, coming back, there are fantastic molecular labs and fantastic histopathological labs, trying to decipher this is going to be quite difficult. The other thing about the nodopathies and paranodopathies as a concept, obviously we need locally to develop the antibodies in 2 or 3 labs, but India that way is fortunate. The private sector picks up very quickly. So sooner or later, somewhere we will have the antibodies, and only when we will have the antibodies, we will really know over the next 2-3 years what do we see, what commonly we see here. And then we will come around to what Dr. Vishnu was saying, doing trials to know how quickly should we move to treat these diseases. I mean, we all see GBS type of presentations where they become paralyzed in 24 hours and they go on ventilate. And the clinician inside you knows that something terrible is happening. But then you have your method, you'll first give X, then you'll give Y and go on climbing. So there may be a role for a more aggressive therapy early on in those who are very severely affected. But the paradigms will need to be developed very well, because the severe ones also have severe problems. Like the patient that Dr. Varsha showed, Shlok. I think going through the standard steps, he was doing okay, little bit better, little bit not better. But when we went to rituximab literally wiped out whatever was there. And the boy really became so much better that we thought, why didn't we use this therapy earlier? So I think the paradigms will evolve. But for the paradigms to evolve for serious patients, we will need background data as to how quickly can we move and when. So those are the areas where I think understanding and therapeutics will probably change in time as we become more confident with our drugs, like rituximab. Some people are talking about other monoclonal antibodies. We'll probably use them more and more. Like rituximab has made its appearance so much in myasthenia gravis, so much in multiple sclerosis, and so many other diseases, and quite early on. So we may be looking at paradigm changing in time to come. So I think you covered three beautiful areas. So the choice of the areas that you covered were very good, Rakesh and Vishnu, and I think must compliment. Also, there were almost 100 or 120 people listening, so we must compliment all of them. it's not easy at this time of the day to listen to academic talks. And lastly, I must thank Gagandeep and Meenakshi to allow the neuromuscular subsection to do this. So thank you very much. I think let's keep it open for discussion for a couple of minutes before we close. It's 3 minutes to 10.
Thank you very much. And can we have some questions or discussion? If anybody has any questions? Yes, sir.
Actually, I've got one suggestion. Today's 3 topics are quite heavy. Yes. And I think people will take time to assimilate what has been said, and then they may want to think and have questions. So if that is so, will you keep some line open for them to ask questions, maybe through Bhavesh or Bhavesh, if Mansi, Bhavesh, if you're there, if you can receive the questions and send them to the speakers. I thought that all 3 topics, they will need to assimilate, and then the questions will come afterwards.
Yes. Yes, sir. That I think we can have that. I'll tell Asmita or Bhavesh to just collect those questions and then send to the speakers.
Yeah.
Yes, sir. It's okay.
That's very kind of.
And sir, and regarding this CISP, this article which I was reading, the time taken to diagnose was actually ran into years and years. One of the case was after 10 years, it came to that this could be a CISP. So why it is so difficult really to pick up the cases of CISPs?
We are a little bit spoiled by the availability of the MRI now and our mental makeup to use it. So we are doing it quickly. Like, you will be very surprised. The case that this one showed, Darshan showed, the diagnostic time was what, 3 days, Varsha? From the time he presented to us, in three days, we had the
practically 3 days, sir. Practically 3 days.
So I think
that's all because we've been seeing.
I mean, we knew about the condition. So, but the point that you're making is very interesting. That these people were diagnosed so many years into the illness, and still the immunotherapy helped them to an extent. So there is something there that doesn't go away. It stays amenable to therapy even after years. And there is a report of a pure motor brachial plexopathy in a violinist, which was there for 22 years before it was diagnosed. And it responded to IVIG 22 years down the line. So that's something peculiar. Also, the CISP, I have my 1 or 2 questions which are unanswered. One is, in the first paper, where did they take biopsy from? I wrote this to Dick Jr., but I didn't get any answer. I mean, if it's pure CISP, then you have to do something proximal to the ganglia. And none of our guys say that we reach there. Unless you do a laminectomy, you can't reach there. So where are the biopsies from? Otherwise, all those cases were also CISP plus. Because sensory rootlet biopsy post-ganglionic will mean it is CISP plus. And then there is this nomenclature issue. In one of our papers, we called it CIS capital M small P. CISMP, which is like CISP plus. But I think these sort of things happen all the time in literature.
Yeah, I was going to ask that only. So when you have the terminology issues, so even
my feeling is that all 3 conditions are the same.
Yeah,
their core is the same. Proximal involvement of the roots. Sometimes more sensory, sometimes more motor. And we published 8 or 10 cases where each case, clinically, when it looked like a sensory ataxia, electrophysiologically also there was a motor component. So they're all the same, but for whatever are the reasons, either the sensory or the motor becomes the dominant one. Again, we come down to the antigenicity and pathophysiology, immunopathophysiology.
Excellent.
Food for thought. Yeah.
So I think we had an excellent discussion on sensory ataxic syndromes. And on top of that, some excellent comments by sir. And we had a nice meeting. So I think we can close now.
Before closing, Rakesh, I think we should tell all the audience that this session with these sessions will continue. So we, as Kadrikar sir has told, we have 6 sessions lined up, but we will continue after the 6 sessions also the next year into it. So we would like to give chances to most of the centers. I think every center should get a chance to represent, and the idea is to give 1.5 hours to them and to the team to prepare cases or approach to who each one can present and at their center and showcase their center's work in this meeting. So we'll have 6 meetings. After that, if you want to have joined this system, just email Rakesh or me, and then I think we can take it forward from there. Thank you.
Do you want to announce the next date?
Yeah. So the next meeting is on April 26th, same time, and it will be conducted by Government Medical College at Trivandrum, Dr. Mary I. She will be doing that, and we'll be informing you much before.
Yeah. She's a pediatric neurologist, so it should be interesting.
She will have a full 1.5 hour meeting, and do join us that time also.
So our timing is the last Wednesday of the month.
Every second month.
Every 2 months. Yeah. Okay, then we'll close it out.
Yeah. Thank you so much.
Thank you.
Thank you, everyone.
Thank you, sir. Thank you so much. Thank you, Megha Prashad. Bye, Vishnu.
Yeah. Bye.
Bye. Yes.
Thank you all.
Bye-bye.